A very good evening and welcome you all for the fourth National Pleural MDT. Uh, this we have been doing since last 6 months. We are regularly conducting National Pleural MDT every alternate month, and this is our fourth time we are doing it. And thanks to all the pulmonologists, thoracic surgeons, residents who have been a part of this journey. Uh, Today, we will be having three cases presented by three case presenters from across India. We have five panelists in our session today, and we are the two moderators, myself and Dr. Richa Gupta. To start with, I'll just introduce the case presenters. The first case presenter is Dr. Urvashi Paliwal. She is a second year DNB resident from Pranayam Lung and Heart Institute, Vadodara. Then we have my dear friend Dr. Ravi Doshi, who is a senior consultant and head, Department of Pulmonary Medicine at Kokilaben Hospital, Indore. And the third case presenter is Dr. Rishabh Ranjan Singh. He is the third year DNB resident from Ramkrishna Care Hospital, Raipur. We have five experts today in our panel discussion. The first and foremost is Dr. Manoj Goel, sir, who is the Principal Director and Head, Department of Pulmonary Critical Care and Sleep Medicine at Fortis Memorial Research Institute, Gurugram. Then we have Dr. Apar Jindal, who is the Head of the Department of Pulmonary Critical Care Medicine, Program Director, Lung Transplant at Gleneagles Health City, Chennai. Then we have Dr. Dipesh Maskey, who is the Senior Consultant Pulmonologist at MMI Narayana Multispeciality Hospital, Raipur. Then we have Dr. Sukhram Bishnoi, who is the only surgeon in today's panel discussion. Dr. Sukhram is a Senior Consultant Thoracic Surgeon at the Institute of Chest Surgery at Medanta Hospital, Gurugram. And last and not the least, Dr. Arpan Shah, who is the pulmonologist and medical director at Pranayam Lung and Heart Institute at Vadodara, Gujarat. So we'll start the panel discussion after each case. We are two moderators in today's session. Myself, Dr. Sushil Jain. I'm the head of the Department of Pulmonology at Ramkrishna Care Hospital, Raipur. And my colleague, Dr. Richa Gupta, who is the professor and head Department of Respiratory Medicine at CMC Vellore. So now we'll start the session of today. The first case will be presented by Dr. Urvashi. Dr. Urvashi, please share your screen and start the case.
Yes, sir. Good evening, everyone. I am Dr. Urvashi Paliwal. I am a second year respiratory medicine resident at Pranayam Lungs and Heart Institute, and this is my institute. So, presenting to you a case of persistent bronchopulmonary fistula, which was not repaired even after bronchoscopic or by surgical approaches. So, a 71-year-old retired non-smoker custom officer who was a known case of diabetes and hypertension presented with cough with expectoration, breathlessness on exertion, and he initially stayed in USA. Initial treatment was done for his symptoms, but symptoms did not subside. Further, he was advised PET scan there, which was suggestive of large cavitary lesions seen in left lung, which were non-hypermetabolic with unmediastinal lymphadenopathy seen. Patient then came back to India. Uh,
Urvashi, can you
yes,
go
ma'am.
back? I would just like to stop here and ask our esteemed panelist, based on this imaging picture, what we have from US, it's a PET scan. What would be your differentials very quickly, one by one? Can we just put it up here? Looking at this single image, I know we don't have the entire films, but what do we think about here? Because this will guide us what and how the treatment would go further. Manoj sir?
Thank you, Dr. Richa. So, as I can see, this patient is having some sort of a chronic illness, as a matter of fact, and what I can see is that the right the lung seems to be quite okay, but there is a constriction, or there is a reduction in the size of the left hemithorax, and there I can see there is pleural thickening. I think there is a thick wall cavity, or it may be a pleural thickening of the visceral pleura and the parietal pleura with the fluid level. And then I can see, some athletic lung underneath, which is showing fibrosis and bronchiectasis. So I think my differential in this case would be possibly a chronic empyema, because there is a lot of crowding of the ribs and a lot of constriction of the left hemithorax. Of course, you can also have this kind of an image, but looking at this CT image where you've got this obtuse angle going on all through the hemithorax in the periphery of the thickened pleura. So my first positive would be it's a chronic empyema with thickened pleura and some fluid level, maybe a chronic pus inside. And then there is underlying atelectasis, fibroatelectasis. Of course, second differential would be a sort of cavity. And looking at this thing, I think it would be more of an infective pathology rather than any malignant pathology or any inflammatory pathology. So if you look at the infective, chronic infective pathology, then of course chronic empyemas and tuberculosis, these are the two things that come to my mind.
Yes, sir. So very well said. Sir has described it very nicely, and as we can see on the left side, there is crowding of the rib, and even the pleural, this I don't know if I'm able to make the arrow scene, but we can see there is a calcification of the parietal pleura as well, which says that this is something which is very chronic, not something of acute or subacute onset, which surprisingly the patient's symptoms doesn't point towards that. So maybe something was there which was there but not taken care of. Carry on.
History
Probably,
may be not taken properly, possibly.
yeah,
Right.
probably because of his underlying immune status. He was a known diabetic for 10 years and he was traveling to and fro. So that was one of the reasons he didn't bother much. And this could be the reason of this long standing possible, as
Hmm.
sir described.
Diabetes also, if it is uncontrolled, then probably, but I don't know what was the status. Was it diabetes was uncontrolled because it
It was
changes?
on the higher side, ma'am, when
Oh,
he came, not completely uncontrolled, but the HbA1c was around, if I remember correctly, it was around 8.59. So we can
okay.
put it into label of as an uncontrolled kind of.
Uncontrolled. Sure, sure. Go ahead, Urvashi.
So then the patient came back to India. His first investigation included a bronchoscopy, and bronchoalveolar lavage was done, which further showed the growth of aspergillus in it. Since he was developing an empyema, abscess drainage was also done. Aspiration of around 100 ml of foul-smelling pus was done, and it found that fungal element growth was seen. This patient was put on voriconazole. Since the empyema was increasing and the symptoms were also further increasing,
Yes,
ICD insertion was done.
Dr. Urvashi, 1 second. You said this is an empyema, and on your slide it is written abscess drainage. So was it an empyema or an abscess? Because I was the impression that someone has put a drain in the abscess, or it was in the empyema. What was it?
Initially, sir, it was initial CD findings said that it was an abscess, so abscess drainage was attempted. But then, even after abscess drainage, it did not resolve and further kept on increasing. Successive CT scans showed that the abscess was now increasing and getting converted into thick loculated effusions, which was empyema. So, after around 1 month, patient repeated his scans. It was found that patient has now developed loculated empyemas for which ICD insertion was attempted.
But
It was
empyema
actually,
was there. Sorry, Arpan, please carry on.
ma'am, this is a course before he met, about 12 months before he came to our hospital.
Right,
And all
right,
this course that we are describing in next few slides is done before that.
right.
Considering an abscess, they inserted an ICD, and that's when the whole saga started.
But
After that,
that, I mean, if you look at the PET CT scan, as Sir said, certainly there was an element of pleural collection as well. And within whether there was an abscess which is ruptured and caused an effusion, we don't know. But I would like to ask our only surgeon here, Dr. Bishnoi, what do you think with this CT scan and with the bronchoscopy picture where the bowel was done? It looks like there were, purulent secretions were there in the scopy. What has been done, and then what do you think? What is could have been better if the surgeons would have been, brought in early, or it was okay to go ahead and do whatever medical management is being done? Dr. Bishnoi?
Ma'am, yeah, ma'am. Ma'am, first of all, I would like to have that whole CT scan where the lung window and mediastinal window I can have the access, so I can make my opinion. Because looking at this situation, there are the sign which is it's a chronic empyema calcified, which may be there for years. It is not an acute situation as far as we're concerned of the empyema. Now, what is there in the lung, I'm not able to make out from this window, whether it's a cavity or whether it's in the chronically collapsed lung. I'm not sure what it is, because sometimes the both the situation can coexist.
True.
So, unfortunately, Dr. Bishnoi, we just have this one thing. As he was in the US, no, he did not have access to his reports. He smartly took that one picture in his mobile, and that's what he gave us. So that's the only image of the pet that we have. He took this picture in his mobile, and so we were also wondering what to do.
So
Yeah, agreed.
there was no imaging repeated in India when the patient came in.
That was done post
Before,
ICU.
okay,
No.
okay, sure.
So these are the scans post ICD insertion. We can see an ICD in situ along with developing empyema. Even after ICD insertion, patient now had developed a bronchopleural fistula. There was persistent air leakage. Patient still complained of breathing difficulty and coughing. Now the patient was posted for emergency decalcification of the empyema cavity along with decortication. But since the BPF repair went unsuccessful, augmental transposition was done so that the BPF could be closed. Post-op day 1, sadly patient again had a persistent air leak with an ICD in situ. Pleural biopsies done then showed the presence of invasive fungal infection, which was aspergillus, but tissue invasion seen. Now almost a year had passed and patient had a ICD in situ, but his symptoms did not resolve. He still had cough, breathlessness, along with persistent air leakage. He then went to Ahmedabad for further management. There, the patient was advised bronchoscopic spigot placement. Thus, he underwent a bronchoscopic spigot placement, but unfortunately, the first spigot got expelled out because of excess of coughing. Thus, on 16th of Jan 2024, a reinsertion was done for another spigot.
Dr. Urvashi, just hold on for a second.
Yes.
Now, this is an important question for the panelist. So, would you consider spigot placement in such a situation, or would you not do it? So, what's your opinion, Dr. Arpan?
I won't, because it's an infective thing that is there. I mean, and they have already attempted an unsuccessful surgical repair of that. Putting in a spigot where you don't know the size, that's what they did. They did a 2 mm, 3 mm, 3 spigots. After insertion of spigot, next day patient had a bout of coughing. It just came out in his cough. 2 were remaining, and they re-attempted with a 5 mm. So I won't, in this particular case, wherever the infective lesion is there in the pleural cavity, in my experience, putting in a spigot is not advisable. I'm not
The
sure.
only question here is because if surgery is practically not doable or there is a problem with surgery, what else you would do then at that stage in this particular situation?
That's what we have done, coming down. But I think, yeah, Manoj sir.
Manoj sir, please.
I think this case had to be managed by surgical route only.
Correct.
The lung is collapsed, fibrosed. There is a chronic calcified empyema there. Pus is there. Fungus infection is there. So nothing of medical sort is going to help in this patient, as a matter of fact.
Agreed, sir.
I totally agree with Dr. Arpan that this spigot would not work in this patient. Even if we do something, the problem is this airspace will not close. Whatever we have to do, we have to see that the residual cavity or residual empyema has to close. It has to obliterate, which is not going to happen because it is so calcified and dense, densely adherent. And underlying lung is also not healthy, so which is chronically collapsed and fibrobronchiectatic. So I think the surgery would be the best option in this patient, where they can go for maybe, as I can see in these images, the left upper lobe is quite secure. So maybe a left lobe lobectomy with pleurectomy might have been a better.
They attempted that at that point in time when they went in, but it was too adherent and bleeding happened. So they just closed up with an omental flap. Dr.
So again,
Bishnoi
in these
maybe.
patients, yeah. So I think in these patients, it's better to go for thoracoplasty because again, the mental patch is not going to work there. It's going to get infected,
Active infection
and the
is there.
problem will not solve. So these cases would require, in fact, either you do make a window thoracostomy, or do a thoracoplasty.
Yeah.
That is the option. Perhaps you will do first the window thoracotomy, so that the pus drains out and you clean it. You can do a lavage over a period of time, which may take 3 to 4 months and 5 months. Continue with the antifungal treatment and the antibiotics. And once the infections come under control, then do a thoracoplasty. That was what I would do. I think doing a lobectomy in these patients again very difficult. It's going to be very challenging. And again, if you do a lobectomy, it will be very difficult to expect the remaining left upper lobe to
Exactly.
fill the cavity which is left over there. So I think this would require a staged approach with a window thoracotomy and then a large window made, and then later on thoracoplasty. That would be, I think, be the idea. Maybe the surgeons can tell us better.
I think that's probably the right approach what you discussed, sir. So can let us move on to the next slide.
So now when the patient came to us, he was with the condition that he had an ICD in situ for nearly 1.5 years. He still had symptoms of persistent cough and breathlessness, and plus persistent air leakage was present.
Roshi, click on the icon there. It will play, or you can.
All the available of VPI via both bronchoscopic approach as well as by surgical approach, they all were not successful in this case. We straight away went for open drainage of this patient.
Yeah.
I think her voice is cutting, sir. It's
Arpan, you
buffering.
can
Yeah,
describe.
I'll just describe. Urvashi, you can just hold on if the voice is buffering. So I
Dr. Urvashi, can you hold on for a minute? Your voice is cracking.
yeah,
Yes, sir.
I'll just take over, sir. Urvashi, your network is closing, so you stop. I'll take over.
Yes, sir.
So can you just go back to one slide if possible? So after Spigot, yeah, just one back, still back. Yeah, go put on this chronic long-standing air leak. These are a couple of videos that I put in that was done after Spigot. The first one is after Spigot, and then they came to our hospital. No, go to forward slides. This is the Spigot
Can we just for the
insertion.
surgical aspect?
Yeah. Next slide, please. Next slide.
It's like
It's
Dr.
next.
Urvashi. Next slide, please.
So what we did was we did an open drainage in this patient. We fenestrated with the ribs. We cut open the ribs, and then we removed all the pus that was there. Urvashi, can you go on to the slides, please?
Yes, sir.
Sorry about the technical error. Yeah, this was the course at our hospital where we did the open drainage. We cut open the ribs, created a cavity. Can you go on to the next slide, Urvashi? Just go on to the next slide, Urvashi.
Yeah, she start.
I'll share it from my. Urvashi, stop sharing it. I'll do it. Just a minute. I'll
Sorry
have
for the technical delay.
technical.
Arpan, you start sharing it from your computer.
Yeah, I'm doing it. It's not
You
getting
want
shared. No.
shared or shall I share, Arpan, for
Yeah,
you?
can you share it, please? Yeah,
Yeah, yeah.
if you
One
yes.
sec. Huh?
I'm
Just
I'm literally sorry about this
no worries, no
glitch.
worries.
No,
One
no
sec.
issues. Please.
I mean, you can skip these videos. We understand you did an open thoracostomy and
Only
can move
for
Yeah,
ahead from
yeah,
there.
yeah, yeah.
Hmm.
I don't know where it has gone. Is this the old one?
No, not this one, ma'am. The other one I
The
sent.
other one? Okay, okay. I don't think where it has gone.
Must be I
We
sent
can
it.
move on. They have
We
made
can
a
move
window
on, I
thoracostomy.
think.
Yeah.
Yeah,
So
yeah.
what we
Move
did
on.
was that we did the open
Stop
drainage
sharing.
with that.
Hmm?
We did an open drainage, and then we did a daily dressing. I wanted to show you. You can share that, ma'am. The images are the same. That even
Okay.
that presentation has the same images.
Sure, sure, sure. We'll do that.
Show it, yeah. So we did a daily dressing for about couple of months, and that's how the patient came to us. It has nicely now healed up, and this is just show, ma'am, the after this.
yeah.
Yeah, just yeah, this were the follow-up dressings on 10th July 2024. Can you go on to the next slide? This is 5th August, and you can see the underlying lung that has improved significantly for the 5th August 2024, right, ma'am? And this is 25th August. These are all the photos, and there's one more photo where it's completely healed. This is the X-ray that is there of post open drainage. There is no more pus drainage that is coming out. Patient is symptomatically better. He has put on about 7 or 8 kgs of weight. The X-ray looks like that, but clinically there is no fever. The coughing is practically gone. No breathlessness is there.
Mhm.
I mean, that presentation, there is one slide that is there, the last one, where we have shown how the
Should I
healed
share it?
open drainage.
Should I share it?
Yes, please, sir.
1 second. I'll just see if I can. Second. Unable to share it. 1 second. Not able to.
Sir, it's okay. It's fine.
Yeah.
So that's
But
what we did. And then in December this year, about 1.5 months, he presented again back to us with coughing, fever, and a certain weight loss, about 2 or 3 kgs. So it was there. We did an X-ray, which was more or less, yes, sir. This one, this presentation is there. Can you go on to, yeah, this the image after that.
one
After
second.
28th Feb 2025, there is
I'll
one more.
just come.
Yeah,
I'll come.
this is how he has healed up now.
I'll
You can
just.
see the whole cavity is gone. It's completely better. There is no leakages from in of this. He's moving around very nicely with this without thing. A little bit of functional compromises there, and cosmetically, of course, it looks like that. But this is below the shirt, so hardly matters. And this is the X-ray that is there. Still looks the same. Now in December first week, he came to me with weight loss of about 3 or 4 kgs. His symptoms had slightly worsened, so I thought that I'll just do one bronch. I'll look at it from inside as well. Collected the ball, which was AFB +1, but gene expert was very low, so I sent it for cultures as well. Sir, next slide, please. The cultures were suggestive of Mycobacterium abscessus. So we did the speciation. Culture was positive for AFD. So we did the speciation, which turned out to be in NTM. And in the speciation turned out to be Mycobacterium abscessus complex, which was rapidly growing, one of the rapidly growing ones. And we did the culture sensitivity with that, which was sensitive to amikacin and amikacin, tobramycin, cefoxitin, and TG cycline.
Mhm.
And ciprofloxacin, of course. No one uses it. I don't know. I'm not sure about that. So this was the thing. So this is the case as of now. We have put him on amikacin doxy. We have continued with it. Clinically is better. He's regained that 3 kgs of weight loss that has gone, and there is no fever as of now. Slight coughing is there, but not that bad. He's got back to his routine. So I'd like to end this presentation by saying that the greatest enemy, by this very famous quote by Stephen Hawking, that the greatest enemy of knowledge is not ignorance, it's the illusion of knowledge that is there between all of us. So thank you. And this is my newer unit, 140 bedded lung institute, which we started about a couple of months back. And with that, I'm open to questions. Thank you. And extremely sorry for the technical glitch that happened.
Thank you, Dr. Arpan and Dr. Urvashi, for this excellent case. I would like to have input from Dr. Sukhram. What is your take in this case, and how would you have managed this case better? What you would have done at any point of time? Would you have, like you felt that I would have managed this case better than what it has been done?
Sir, first of all, I would like to go back to the CT scan which was being done at the in India. So I can see only images. I would have loved to have on video running. So if in the situation where the patient is quite okay, physically fit, and upper lobe is healthy, in current scenario, I would have done the decortication all along with the lower lobectomy, where I would shorted the BPF part which is being leaking continuously in the post-operative duration. So with the, it is basically it's a chronic empyema, and with the chronic empyema led to the destruction of the lower lobe and maybe the secondary infection which led to the formation of the BPF. This is what look like the pathology in this patient. So my take was I would have done the lower lobectomy along with the decortication. That was my first choice, if provided the patient is fit and the BPF was only involving the lower lobe. The upper lobe should have been healthy.
Okay.
Sir, yeah. So I would just like to counteract a little bit here, and I'm just open to that. You said about a lower lobe lobectomy with decortication and BPF repair. Sir, it was quite effective, number one. Number two, in the first surgery, which they could not perform the decortication and the lobectomy, the operative notes, we have not put it in the interest of the time. It was strictly adhered to that. So could it have happened that you may have ended up doing a pneumonectomy and whatever normal lung in the left upper lobe left would have also gone with that? Could that been a possibility? That was the counteracting reason we went for an open drainage rather than going for reattempting a lobectomy with a decortication, because that was one of the thought processes that even I had when this patient came to me, that we will reattempt doing a lobectomy, but then we went through the operative notes, we went through the clinical condition of patient, and that's the reason we went for an open drainage.
I think I will agree with Dr. Arpan more. The pleura is quite thickened. It's also involving the upper lobe. If they would have done a decortication, there would have been excessive leak from the upper lobe also. And it was an infected cavity. And in this situation, this could have been a very messy situation. And we didn't lose the left upper lobe by doing this open thoracotomy. So this was a safer. See, going ahead with doing a pneumonectomy in this patient and then leading to a stump formation which is leaking all through would have been a mess in this patient. Then there was no other option but to do a pneumonectomy later on. So I think this was a very nicely done case where you went ahead with a safer option, did an open window thoracotomy, cleaned up the entire material there, the pus there, gave in antibiotics and antifungal, did the daily dressing, and that worked for this patient. And second point is about this NTM which is there. I think we have to take that with a pinch of salt, because for NTM, this is a colonizer. And until the patient is hugely symptomatic and you show this NTM twice in 2 cultures or 2 sputum examination, then I think possibly you consider as the etiology. So maybe NTM would have been a colonizer in this patient.
Sir, just to counter on that, NTM we are now seeing more often than what we used to see before. That is one thing. And if you are getting an NTM in a symptomatic patient who have a radiological features, and if your BAL is coming positive, culture positive, then probably you need to treat that. And
I agree with you, Sushil. I think that this is not the forum we are not going discussing NTM. We can go on discussing that.
Just the one thing.
But yes, if you go ahead, we have to see whether, I would have tried this patient antibiotics first and see whether he's improved or not. If after giving antibiotics, this patient did not improve, then possibly I would have again did a repeat bronchoscopy, look for this NTM again, and at least show that it's there twice, and then I would have treated. So that would have been the approach. Instead of going ahead with treating NTM straight away, I would have treated this patient with antibiotics first.
Okay.
So can I say something?
Yes, sir. Yes, Dr. Sukhram.
So
Yes.
what I am talking about, the patient landed in the India, and that time if CT scan was done, and if that was the CT scan, and its only the issue was that a lower lobe was a cavity lesion or lower lobe having BPF with empyema, my take will be doing the lower lobectomy, not the pneumonectomy. I did not say what I mean, and what I'm saying is I mean it. I am not contenting this patient for pneumonectomy. Is the only lobectomy
If you the
with
patient have
decortication.
been to you at the early stage, at the
No, sir. Which stage which landed in India with that decalcified pleura with all these things? This is the daily routine practice in thoracic surgery, where the all chronic empyemas are coming after 15 years with the same situation and similar CT scan. So those patients will be ideally should be managed with the low if there is a BPF lower lobectomy with decortication. That
So
is the first thing.
Dr.
Sir,
Sukhram,
I agree with you, but the only mess that was done was that ICD was inserted in the initial phase, which went into the
So now
cavity.
if there was no
If the patient had, I absolutely agree that if the moment someone would have thought about doing a lower lobectomy decortication in the first place, as soon as he landed, that was okay. But once the ICD was done, then the whole mess started. That's what my take was, because this patient came to me after 1.5 years of moving around with all this.
Yeah, so the most empyemas are infective and pleural cavity with empyema lung resection is the routine practice. It's not it does not cause the post-operative BPF. The chances of post-lobectomy BPF is less than 1%, even in the infective situation. I'm not talking about the malignancy. Even in infective pathology, it is less than 1%. Now, coming back to the surgeon was not able to do it, or whatever the expertise was available, what is being done. After that, the second choice would have been the window, because already the whatever is being done and surgery failed, and there's no other option which is being left to this patient. Now, in that situation, I would like to do the window, and we can continue with the window. Now this window has been closed and NTM is inside. So NTM is a very notorious thing. It keep on recurring unless you keep it open. So this patient will have recurring problem. Once you stop this antibiotic, he will again have a problem. So possibility is that we will have to open the re-window. This is what we have done in the 15-20 cases of NTM. We did VATS decortication. Patient after 2 years he come with recurrence. Did window, the window got closed. 2 years later he again have with this problem. So I don't know what is the ideal solution, but NTM is mostly once the NTM get infected, it will trouble us lifelong. That's what my understanding is.
Yeah, couple of things here to counteract the whole scenario is that if you look at the serial X-rays, the presentation was not, because of the technical glitch, I could not show you the serial X-rays. But over last 1.5 years, they are practically the same. And this patient has gone multiple bronchs initially because of the spigots and everything. And as Manoj sir said, that this is probably a colonizer. He's not having that any major symptoms. And my only reason for treating him for 3 weeks as of now with antibiotics as per culture reports is that we may not face it. Now, what you say, I think we'll just have to follow this up and keep a close tab on what happens, because we cannot predict in this case.
So Dr.
Because
Sukhram,
once
the
problem is that once the window got closed, this patient started having clinical features again.
So that's why, Dr. Sukhram, the second step that we should go ahead and do a thoracoplasty in this patient. Do you think it is not practically possible?
Sir, thoracoplasty, upper lobe is healthy and hearty. Why should we do thoracoplasty in this patient?
The lower lobe
If at all we have to do is a muscle plasty. If there is a given option, if this gentleman has a muscle, we put the muscle inside and close it. That is the second choice we can do.
Somehow this cavity has to be closed.
Yes, sir. Muscle is a better choice, sir. Rather than doing thoracoplasty, because lower down it is not possible to do the thoracoplasty in this patient.
Okay.
Okay.
So if you, Dr. Arpan, leave this cavity there, he's going to have the problem, or you keep the window open. Make sure the window is open and you keep lavaging this patient to keep doing the washings.
So how long do we do that?
Lifelong. This becomes a lifelong procedure then.
You have to revise this window. This window will be revised, because how much antibiotic you put it, every 3 months this patient will be at your clinic with the same problem.
See, problem after decortication, lobectomy is that the pleural space has to be closed. It has to be obliterated. If it is not obliterated, it's going to create problem forever. So either you keep it open from outside or close it.
So my other take is, sir, if it's an open, in one of the patients we have done about 8 or 9 so far in last about a decade at my place. If it remains open, could we, Dr. Sukhram, put some kind of a flap for cosmetic reasons, or it won't work?
Yeah, muscle flap. If cavity is healthy, culture is negative, take the muscle flap, that may be a cross flap or free flap, whatever it is, and put it, and you can close it with that. We do on regular basis.
More often than not, we have seen that these patients end up into
now
and
we
the
stop
last
the
question, sir.
discussion.
I'll just
Yeah,
take
please.
10 seconds. As you said that NTMs are there, which are notorious. In spite of growing that, do you think a muscle flap would work?
No, culture negative, I mean it. Culture negative. If culture is positive, don't
Fine.
put muscle flap.
Fine.
So in NTM, no question of putting muscle flap in this patient.
All right, sir. Right. Thank you.
Thank you. Thank you.
I'll just say two words. I think this patient, we need to understand that we should not unnecessarily deal into what is not our forte. Probably the patient we knew, as Sir Manoj sir has rightly said, it is a chronic patient. Everything was there. On bronchoscopy, there was fungal infection. So a person who is having uncontrolled diabetes, who is having chronic empyema, and bowel is showing fungal, probably a good early referral to the surgeon would have saved all the mess which has happened all through 1.5 year. Probably that would be the message, that we should be referring to Dr. Sukhram Bishnoi early in the course rather than messing with ourselves.
Yeah.
Thank you,
Very well
Richa.
said,
That
ma'am.
was a
Surgeons are
very
always
well.
the boss. No
Yeah,
problem.
thank you. So I think now we move on to a next case. Dr. Ravi. Ravi, I think this is another interesting case for today.
Very good evening, all of you.
Yeah.
Yeah. So thank you for giving me an opportunity to present this case. Means I am 4th year resident at Kokilaben Dhirubhai Ambani Hospital. I happened to be referred this case by a fellow friend of mine, because this patient was very perplexed. But I think at the end of it, I was left more perplexed. So I thought better to share it over here. As a 70-year-old male, he was referred to us for evaluation of a right-sided recurrent pleural effusion. He was suffering from the same for the past 2 years and needed tapping practically every month, which he reports to be straw-colored. He has a very efficient son who used to carry photographs of everything and showed, sir, ye aisa color hai, ye aisa color hai. It was always right-sided. And his symptoms, whenever he presented, he tells, were of shortness of breath, dry cough, and chest discomfort. And this was the same with which he presented to me. On examination, an elderly gentleman of around saturation 90%, on which he was relatively stable, respiratory rate of 25, A febrile. He had a dull note in the right infrascapular area with very much diminished entry in the same region. Now, if we go to his past history, he was a diagnosed case of CML in 2019, and he was started on a chemotherapy agent, dasatinib. So he was a senior gentleman of quite some reputation. He was under treatment, though he was from Indore, but he was on regular treatment for the same at Mumbai under a hemato-oncologist. Currently, the chemotherapy was something else. Now he was on asciminib. So in when we went into more detail to his history, we came to know that in 2024 he was admitted with shortness of breath and cough under the hemato-oncologist. There he was diagnosed to have a bilateral pleural effusion, for which a tapping was done. At that time, right-sided effusion came. This was around 5 years of after the diagnosis of CML, till when he was using the drug dasatinib. At this point of time, he was advised to stop dasatinib. His chemotherapy was changed from dasatinib to imatinib because at that point of time it was told that it is dasatinib which is the curative, which is the causative agent of this chylothorax. Since the patient came to me subsequently, he did not have any records of this chylothorax, but he had photographs showing that it was chyle-like fluid. Subsequently, the patient kept on having symptoms despite the dasatinib being stopped, and he required multiple tappings. Almost 6 times tappings were done, and every time the fluid he vouches was straw colored, and straw colored. So again, prior to coming to me, he had a tapping done in just around 3-4 months prior to coming to me, and it was an exudative lymphocytic infusion with very high ADA levels. At that point of time, he was started on ATT in view of those reports, and the patient took ATT for around 3 to 4 months, but he did not have any relief in his symptoms. The tappings continued and he continued to be symptomatic. Ultimately, he went to Bombay and again he was admitted in Mumbai under the hematologist, where the pleural tapping done this time did not show anything except a simple exudative effusion, and they stopped the ATT. And again, they revised the chemotherapy. This was his fourth revision, and then he came on his current drug, which is asciminib, which is considered to be a very novel and good drug for CML with very little side effect profile. Then the patient's tapping saga and his symptomatology never ended. The patient presented to us in December 2025 with this particular X-ray, and he told that hardly 2 weeks prior to this, he had gone and was again tapped, and a straw-colored fluid was drained. At this point of time, we thought that we'll evaluate by doing a CT scan. We did a CT scan, and this particular picture came in which on the right side we had a very large homogeneous dense collection with the collapsed lung, and we decided to go in for further evaluation. We thought of planning a medical thoracoscopy for this patient because it was becoming very perplexing that dasatinib was stopped long time ago and the patient was still not improving despite multiple attempts, multiple tapping. We planned the procedure. It was a weekend. We planned the procedure 2-3 days after the CT scan, and we screened both the sides ultrasound. Right sided, we were estimating around 1 to 1.5 liters, and on the left, there was around a hint of 50 to 100 ml of fluid. So we decided to take the patient up for a medical thoracoscopy, and I don't have videos, but I have pictures to show. When we entered, the costal pleura was showing a lot of pleural nodules, and in this there were a lot of pleural nodules which you could appreciate on the costal pleura. They were all multiple pleural nodules, just like you can appreciate. There were 1 or 2 which were of larger size, but mostly they were these small nodules from which we took multiple biopsies, and we sent them for everything from histopathology to microbiology. Whatever we could do, we tried to send. We could aspirate this fluid from the pleural cavity. Now, this was chyle appearing fluid which came out, which surprised all of us because the patient had vouched that for the past 6 months, almost 6 times he was stabbed, but every time straw-colored fluid had come. Never was chyle aspirated from his chest, despite 2 years ago when he was stabbed that time in 2024. So it was very surprising. We aspirated around 1,600 ml of chyle and of chylous fluid, and then when we further evaluated it with the standard protocol of triglyceride and cholesterol, they were all elevated, and it was diagnosed to be a case of chylothorax. Well, subsequently, the pleural biopsy came in, and the pleural biopsy also did not seem to be very helpful because all it could tell us was there was no evidence of any myeloid leukemic infiltration in the biopsy which was submitted. It was just chronic pleuritis with lymphocytes and reactive mesothelial cells. So this became a sort of a mysterious situation for us, where we still don't know what could be the positive reason for those recurrent effusions and the chylothorax which the patient had developed. So at that point of time, we kept a diagnosis of bilateral of chylothorax with secondary to suspected this fluid. Now, one slide I have forgot to include in this. Subsequently, when the patient was being managed, he developed an effusion on the left side also. And when we tapped that left-sided effusion, that also turned out to be a chylothorax. And that was the first time he had developed an effusion on the left. The fluid was again chyle, which we had proven by our analysis. So we ended up with a diagnosis of bilateral chylothorax secondary to drug induced. If it was drug induced, then it was the drug which was given almost 2 years back, which was dasatinib. Subsequently, he had been changed on 4 drugs, or we kept a possible diagnosis of a leukemic involvement with CML, but we couldn't prove anything.
Uh,
We, sir.
yeah, please.
Then the management of this patient, we did a dietary modification. We avoided the long chain free. We gave a long chain free diet. We were giving IV antibiotics because the patient always had some features of infective etiology. He had hypoproteinemia, and this hypoproteinemia we started correcting. And after giving him 2 shots of albumin, what was very surprising to us was the drain on the right side, which we had placed post thoracoscopy, absolutely stopped, and left sided, the part where he had developed the new chylothorax, that also drained off. So hypoproteinemia was corrected. The patient ultimately, after 2 doses of albumin, became absolutely pleural effusion free, and we could remove the drain and sending home. And after, in consultation with the hemato-oncologist, currently we are monitoring the BCR-ABL levels for the leukemia levels, continuing him on the current chemotherapy, because as per the medical oncologist, the current chemotherapy has never been said to have caused chylothorax. So it must be something which was induced by dasatinib.
Uh,
So
Thank you, Ravi. That's a wonderful case. Can I ask Dr. Dipesh? Dipesh, you're here? Dr.
Yes,
Dipesh
yes,
Maskey? Hi.
yes.
Dipesh,
Hello.
now looking at this case scenario, what do you think? What is the possible cause of this bilateral chylothorax? What's your take on it?
In CML patients, the common causes of chylothorax is the most common cause is the drugs. Dasatinib is known to cause chylothorax. And
Mhm,
as Dr. Ravi said that after stopping the there is persistent chylothorax, then we must start looking into the other causes. So what are
mhm,
the other causes that can lead to formation of chyle in a patient's background of CML? Would be the leukemite infiltration of the pleura. But unfortunately, the pleural biopsy is also negative. So that is something rules out. Third thing would be if there is some kind of a thrombosis, central vein thrombosis, they have put a central line, got trauma to, due to trauma of the lymphatic channels. That is something can be done. Another thing is the lymphatic, lymph node infiltrations leading
mhm.
to things. What we can do at the moment is, if we can do a lymphangiogram or MRI
Scintigraphy.
lymphangiogram or lymphangiogram or scintigraphy to
Mhm.
look for the thoracic duct and see if there is any trauma or anything leakage, because that is most commonly bilateral chylothorax. I think we need to look into the thoracic duct.
So I think a lymphangiogram, either conventional or scintigraphy, would have been a good thought, and
Yes.
that could have we would have been able to localize the site of leak. Possibly that may
Yeah.
happen.
So that would
Goel
be
sir,
the
any input from your side?
So I think it's more of a destiny induced because CLL does cause this lymphatic damage, and it can leukemic infiltration, which can cause I'm talking about CLL, chronic lymphocyte leukemia, can cause bilateral chylothorax, but CML it's very unlikely, and then I think it's the destiny which has caused it. That seems to
So
be
drug has
the
been stopped long back. Still, it can continue
yeah,
to
so
cause it.
because it causes lymphatic damage. I mean, we don't know the exact
yes.
cause, why it causes, but most likely it causes diffuse lymphatic damage,
Mhm.
lymphatic obliteration. That's why it causes. So even though this dystrophin is withdrawn, the patient can end up with recurrent chylothorax. But as I totally agree with you, this patient needs the lymphangiography, or MRI or scintigraphy, and maybe then we know what exactly. But it looks like to be due to dysatyl only.
Yes, sir, definitely. Since after correction of the proteins, the effusions resolved, we stopped there. But if they recur, then we have counseled the patient for undergoing a lymphatic study, sir.
So the other thing would be, though dasatinib is known to cause, the chylothorax more commonly than other TKIs, but say about 10% or so. But other uh, TKIs also can cause, though the number is very less, they say less than 1% of all. So still, I believe this could be one of the reasons why it is have. Also wanted to know, Ravi, or maybe some other panelists can add as well. Because you said that hypoalbuminemia was there, and after correction, there is significant improvement in the drainage as well as the size on the left side, which was not drained. Could there be a possibility of nephrotic? Because very rarely this hypoalbuminemia can cause chylothorax in patients with nephrotic syndrome. So I don't know if we have looked into that, though we know CML and all the TKIs which we are giving, but still this is one of the possibilities. Very rare cause, but can happen.
Probably other TKIs must be also causing it. So you should
Yes,
completely stop the TKIs and use some other drug. Possibly that may be the answer.
Yes,
I
sir.
don't know.
Both your points are well taken, Richa ma'am. You might be, matlab you have hit a very relevant point because the creatinine levels of this patient and other renal parameters were borderline in his previous records also. So I think definitely I'll work that part more up. And as far as stopping TKI, the BCR ABL levels of this patient have touched normal. So
okay,
neither the hemato-oncologist, neither the patient's family want to stop it at any cost. So
true.
that is a challenge over there, sir.
Okay.
And unfortunately for CML, I think the TKIs are the drugs.
They are the drugs of
So,
choice. They are the drugs of choice, and I tried to search it up with whatever data whatever resources I have. I couldn't find the current TKI causing chylothorax. So I will try to publish it also, ma'am.
yeah.
Okay.
So just wanted to know from esteemed panelist, in this patient who's been having continuous, will pleurodesis help? We know that we are not able to stop the drug if it is drug induced, or if it is some other cause, lymphangiography is done, it is normal, nephrotic is ruled out, and we are considering as, okay, we don't know the cause. Will pleurodesis help in such patient, or is there any role of surgery, uh, one by one?
Uh, can I make
Yeah, Dr. Sukhram, please.
so? Three things. One is I would like to have a heart workup, because possibly these patients are chronic one, and what they happens is there, because of the congestive these things, they have the obstructive these lymphatics, and that leakage into the cavities. So most of them, I mean, the chest is negative system, and these are the positive capillaries. So there is a more leakage of these things from the capillaries, and positive pressure can cause a problem in these patients. So there is a issue with, because recently we had 3-4 patients who are being referred to us for bilateral chylothorax for the thoracic duct ligation. When we evaluated those patients, obviously none of them are the surgical patient when they have the bilateral chylothorax this thing. So ligating thoracic duct is not the option or ideal I mean treatment for the modality for these patients. So when they did the lymphangiocentrography, they find out that it is leaking from the left and right both side. And then I suggested, because we used to, whenever we find out there is a leakage and accessory ducts are there, we used to refer them for, not for the thoracic duct ligation, rather it's a angioembolization. So you can embolize the cisterna chylis, and above upwards you embolize, and that can sort these patients problem. But surprisingly, these patients they did not do the angioembolization. Rather than doing angioembolization, they decongested these patients with the heart decongestion, and after certain duration, there these issues get sorted. So probably there is a mechanism. I mean, I talked to the cardiac pediatric cardiologist. He gave me one nice explanation. He said, let me give the diuretics and all those things, and we wait for 3-4 weeks, and then we'll see if we want to do the angioembolization in these patients or not. And surprisingly, these patients, I mean, I have follow-up of 6 months and they are doing okay. The last patient is 6 months later and he is doing okay. So there is some mechanism he has explained. I'm on these negative positive pressures and related to something related to heart. But those patients, the 2 or 3 patients were post-Fontan procedure who is having the chylothorax. But he did not say do the angioembolization. Rather, he prepared to have these congestive method, decongestive methods.
Dr. Goel, sir.
Yeah. So, Dr. Richa, of course, Dr. Sukhram might not agree, but this is one situation where surgeons really don't want to intervene too often. They don't like chylothorax to be treated. But I think angiography in this patient, the lymphangiography in this patient is very important. And if they could find the leak and embolize the thoracic duct embolization, that could be done. That seems to be the most possible treatable option for this patient, because surgery is out of question in this patient as it is a bilateral disease. So that seems to be the option. So I think this patient should undergo MRI, lymphangiocentesis and other things to really know where the leak is from. The other thing is, sometimes, I mean, it's this chylothorax or this chyle can leak into the bronchial tree, and then becomes absolutely ossified. We call it a plastic bronchitis. Okay, plastic tracheobronchitis. This chyle going into the bronchial tree, and this is a miserable condition. You can't remove these solidified, calcified chyles from there, and that becomes a very difficult situation. So if you are doing a pleurodesis in these patients, possibly, there is a possibility they may go and leak into the tracheobronchial tree, and then this patient is gone.
Sir,
yeah,
one
please.
thing I would like to say that because if the drainage is too high, then the pleurodesis doesn't work. Couple of malignancy patients, when we were not able to embolize or find exact site of leak, then we considered doing pleurodesis. But then if the drainage is too high, that doesn't work in some patients. However, if we are able to reduce the drainage with the help of, we tried using somatostatins, and then with the dietary measures, and we actually kept the patient NBM. We started with TPN, and then following that we also used somatostatin, and the drainage reduced significantly, and then we did pleurodesis in a couple of patients and it worked there. So possibly that may be one of the things. First, reduce the drainage of the chyle so that there's not too much of fluid which makes pleurodesis ineffective, and then we did the pleurodesis, and it worked in a couple of malignancy patients we tried and we did it. And that's one of the thing I think maybe pleurodesis may be considered in selected patients where nothing else works. Embolization, if it is not doable or not available, maybe in such situations, maybe pleurodesis would help. Any other?
Sir, I
Pleurodesis only work when we are able to remove the triggering factor. In this patient, the triggering factor is his therapy, which we cannot do away with the therapy. So, I mean, when we start, it will start coming again. So the possible option is lymphangiography, and the angioembolization may be a possibility.
Embolization would definitely, if it is accessible.
Because this patient may have the chyle maybe in the abdomen also, not in chest. It maybe there is a possibility it may have in the abdomen also.
First choice is always be to either embolize or do thoracic duct ligation, either whatever is practically doable in a chylothorax. And if that doesn't work, then we need to look to other options. And Dr. Richa, what do you say?
Yeah, I agree completely. And I was just wanted to ask Dr. Bishnoi, not only the surgeons, as Sir said, I think even physicians are very scared of having bilateral chylothorax patients. It's very difficult because we have many patients and almost 99% we are not able to find out what is the cause for it, doing even lymphoscintigraphy and all. Just a small question to Dr. Bishnoi. If nothing is there, you have done all the things, will surgical pleurodesis help in this patient? I'm just asking. I mean, out of this thing.
Only when if it is right-sided.
Okay.
We go in, we do ligate the thoracic duct at the diaphragm level, just entering into the diaphragm level, ligate, and then put the talc, and can come out with the positive pressure therapy, keep patient NPO for a few days, keep on somatostatin, and then we can try that.
Sure.
Sir,
In that case scenario, it may work.
Taking ma'am's question a little forward, would a surgical decortication rather than doing a talc pleurodesis work better off in a case like this? That is what I think ma'am was also trying to ask, rather than doing a talc pleurodesis.
No, decortication of what? I mean, there is no thickened pleura in the parietal and visceral.
No, you just remove it. I mean, if
So we can do the
it's just
pleurectomy.
as a
See,
which sign
so
as a
you
last.
mean to say parietal pleurectomy? You mean to say parietal pleurectomy?
Yes, kind of.
I mean, it is not being reported in the
As a
literature,
last
and I
resort.
don't know. No, because the pleura is not the source of the collection. Source of collection is chyle duct. So in a way, it will be not be helping us, because rather than doing pleurectomy, the talc pleurosis is more proven to be the better agent for the pleurodesis.
Okay. Okay.
So generally what
Dipesh,
happens,
any opinion from you?
I'd like me tell one point from here. So generally surgeons in these cases, when they do a thoracic duct ligation, they invariably do a pleurodesis in these patients because recurrence rate is very high. So they don't come out without doing a pleurodesis, as a matter of fact. So post-op pleurodesis after the thoracic ligation is something that they always do. Is that right, Dr. Sukhram?
Yeah, sir. If I'm doing it for that purpose and ligating thoracic duct, then I will put the talc and come out, and then I would like to keep patient for positive pressure for the certain duration, with keeping them completely NPO and giving somatostatin for a longer duration. Sometimes that it in difficult situation and some syndrome, we have operated 3-4 patient with the similar syndrome, which has the patient has a bilateral these issues, and even after angioembolization they were not responding. So those patients we did, and I mean, we succeeded with those, but there are rare incidents. It is not the routine practice where we will be able to solve this problem.
I think I think we took it like from the surgeon perspective that yes, probably a talc pleurodesis alone may be enough rather than going for surgery. That's what you want to say, Dr. Bishnoi? In case you need a pleurodesis, directly go for a talc pleurodesis through the ICD?
Surgery then talc
If I
pleurodesis.
have to go for pleurodesis, then ligate the duct and then do the pleurodesis, sir.
Okay.
Ligate the thoracic duct and then do the pleurodesis. So at certain extent, we will be able to reduce the drainage.
Thank you. I think I move on to the next question. This is for Dr. Dipesh Maskey. Dipesh, for the interest of the postgraduate students who are listening to this MDT, which are the clinical situations when you suspect a chylothorax, and how do you confirm the diagnosis? Can you help the postgraduates to understand it?
When there is a recurrent infusion, or when you are tapping the fluid, when it is milky white in color, this is the first thing that you start suspecting that you may be dealing with a chylothorax. So that is the time you will send for a triglyceride and a cholesterol. If the triglyceride level is more than 110 and your cholesterol is less than 100, and if possible, you send for chylomicrons. All lab doesn't do for chylomicrons. If triglyceride is more than 110 and chylomicrons are present, then it clinches the diagnosis of chylothorax.
Dr. Sushil, can I add one very important point here?
Yes, sir. Yes,
again,
sir.
for the postgraduates. So what happens is, do not delay the definitive management of these patients. You can try these MCTs and somatostatin and everything,
yes,
but do it for maybe 5 days or 7 days, not more than that, because they tend to lose a lot of proteins.
yes.
So the early surgical intervention, early thoracic ligation or embolization is something which should be done, right? We should not just go on with MCTs and conservative management for ages.
Okay, thank you, sir. Another important point is about 50% of the chylothorax may not be milky. That's another important thing. So in case you're having a recurrent effusion and there's a patient of malignancy or trauma and the fluid is keep on coming, then still you may have to check for chylomicrons. And even early stages of chylothorax, they may not look like a chyle, like doesn't look milky. So that need to be taken into consideration. So I think then we move on to our next question. To Dr. Apar is there or he is not yet joined? Apar not
No,
available.
I think Apar is not able to join. The transformer has gone away,
Yes, there's some
blown
problem
away.
with
He
that.
said
Okay.
that. Yeah.
So next question is to Dr. Arpan. Arpan, how do you do a diagnostic workup? This again for the postgraduates to understand chylothorax. How do you do a diagnostic workup for a patient who comes with a chylothorax? How do you approach that? Arpan?
Yeah, sorry, sir. Yeah. So CT chest with contrast and look at the complete chest and abdomen. That's an ideal, easier way of doing it. And then routine pleural fluid investigation, specifically directing at that thing.
So once you have confirmed the diagnosis, would you like to go ahead further, or just once you have done the diagnosis, that we're looking at how to look at the cause of the chylothorax, or
Yeah, of course. Cause of we need to figure out the cause of, and more often than not, it's infective or particularly if it is traumatic, then I think early surgical referrals are most important rather than messing around with the patients and keeping it for too late. So a CT or MR lymphangioscintigraphies would be an ideal thing to know the small leakages, because that's what are more often than missed.
And Dr. Sushil, we should not forget that TB can also cause
Yeah.
chylothorax, which is
Yes.
endemic our country. And if
True.
you treat them with antibiotic treatment, the problem is sorted out. So that is something that we have to keep in our mind.
So
TB
it's
is an
it's
important cause.
it's the bilateral chylothorax that are a problem. That
bilateral are more troublesome? Agreed.
more troublesome, and that's where the diagnostic dilemmas happen. I mean, unilateral are still manageable,
No, no.
of course, with a lot of pain, but bilateral chylothorax is, I think, that's the diagnostic dilemma.
And majority of them are in fact idiopathic. You're not able to find a cause. Majority of them.
Okay.
Until
And
it's a traumatic one, then otherwise it becomes difficult. But you must look into you must stain these patients look for these patients for gene expert, the TB smears, the AB smear. One should look for that.
Sir, one point which Dr. Bishnoi also pointed out, if the cardiac function is normal, would diuresis help in bilateral chylothorax?
The
Because
only thing
even
that helps is
ideally,
the MCTs, right? Parenteral
yeah,
nutrition initially. These
yeah.
are the concerns, somatostatin. But diuretics, I don't know how they're going to work.
diuretics, no
Yeah.
literature as such for diuretics. Mainly, it's like diet modification, TPN, and then somatostatins. If this medical management doesn't, and drain the fluid. If this doesn't work, then and by the time you do the workup for do your lymphangiogram, either conventional or scintigraphy, and then once you have localized, then if the things are not working, then go ahead with surgery or embolization. I think that would be the approach, sir.
Yeah,
There
in
are
the idiopathic case, when the cause is not there, you can
Mm,
go for thoracic duct ligation in these patients.
mm.
one of my case of I use a mirrorin successfully. The chylothorax bilateral has resolved, but I know it's an anecdotal, can't be recommended. But
Yes.
sometimes mirrorin will help.
Yes,
If
there is some literature for midodrine also. I think there's some literature for that. I think we move on to our last case of today. I request Dr. Rishabh to please start his case.
Good evening, respected panelists and esteemed professors.
Full screen, please.
Full screen.
Yeah,
Um,
I think start, Rishabh. If you're not able to do it, then just start.
Yeah, today we are going to discuss a case on pleural MDR TB. It's basically the patient. One second, sir. Uh, yes. A 32-year-old female patient with no significant past history got admitted to Ramkrishna Hospital in Raipur with chief complaints
I
of.
think your slide is not moving.
Mhm. Yes.
Double click. Yeah, yeah, start.
Yeah, a 32-year-old female patient with no significant past history got admitted to our hospital, Ramkrishna Care, Raipur, with chief complaints of cough, shortness of breath, fever, and right side chest pain since last 15 days. She was having decreased appetite and weight loss since last 1 month. On presentation, her general examination, there was no pallor, icterus, cyanosis, lymphadenopathy, or edema. On respiratory systemic examination, we found that the patient was having right-sided dull note on percussion and decreased breath sounds in infrascapular region, infraaxillary and inframammary area on auscultation. Her routine investigations were done, which were normal. The HB10.4 TLC counts and platelet counts, RFT, LFT were within normal limits. Her chest X-ray was done, which showed right-sided homogeneous opacity with blunting of costophrenic angle. Following which we did a CT scan, which we found that the patient was having moderate pleural effusion on the right side, with no other significant pathology in the lung parenchyma or any kind of mediastinal lymphadenopathy. We following After that we did a pleural fluid tapping. Around 300 ml of deep strocular pleural fluid was aspirated and was sent for investigations, which we found that the patient the pleural fluid report analysis showed exudative lymphocytic effusion with ADA of around 41. Gene expert and cytology both came negative, and then following which these reports were as the pleural reports were inconclusive. The patient was planned for medical thoracoscopy. We did the routine investigations, got the anesthesia clearance, informed consent and fasting, and following the thoracic ultrasound, we did the medical thoracoscopy. In the medical thoracoscopy, we found that the both parietal and visceral pleura were thickened with few nodules that were seen over it. There were also few additions and septations in the right pleural cavity, and we took this multiple biopsies from the right parietal pleura, which were sent for investigations. Around 1200 ml of pleural fluid was drained during the procedure, and a 24 French ICD was placed in that cavity. Next, in the right pleural, the investigations that we sent, the histopathological examination showed the necrotizing granulomatous inflammation. Her gene expert of the right parietal pleura showed the MTB, which was trace and with indeterminate rifampicin resistance. At that time, the AFB culture reports were inconclusive, which that's why we started the patient on standard ATT regime. After 2 weeks, we found that the patient was having the positive culture report in the parietal pleura, in the right parietal pleura, and following
Biopsy. It was a biopsy.
in the pleural biopsy, and following with drug sensitivity testing, we found that the patient is having multi-drug resistant tuberculosis. Isoniazid and rifampicin both were resistant. The final diagnosis were that the patient was having MDR pleural tuberculosis, and the patient was started on treatment for MDR TB, Bipalum regime.
Thank you, Rishabh.
Yes.
I think Dr. Richa.
Yeah, thanks, Risha, for this nice and short and crisp presentation. Would like to ask Dr. Dipesh, who's been sitting very quiet for some time. Dr. Dipesh, do you think, clinically, are there any pointers towards where we can suspect this could be a resistant TB pleural effusion, or it is same as in susceptible?
Madam, only thing is the patient has a history of defaulting medication in the past.
Right.
Has been in contact with a MDR TB patient in the past or in the family. Our patient has, had tuberculosis, recurrent tuberculosis in the past. That is the only time if a patient has a tuberculosis effusion, then we suspect MDR. A patient like this who comes for the first time with this exudative borderline ATA effusion, I think it would be very surprising to find this, drug-resistant tuberculosis.
Yeah, primary pleural MDR is really, really rare, but again, in India, anything is possible. So, a very generalized question, but in a patient like this, now we know that we have a case where pleural biopsy has given us an answer, a culture which is positive. Do we think if we have an exudative lymphocytic effusion with an ADA, maybe even 50, should we do thoracoscopy? Manoj sir? Or should
Actually,
we just treat the patient?
no. So what happens is, what I do in this patient is, the patient is young, has got clinical symptoms of tuberculosis, and with this kind of borderline AD, I would give it a trial of antitubercular treatment for 1 month, and
Right.
see what the patient is doing. If the patient is improving, is gaining weight, is becomes febrile, exercise starts clearing up, I'm okay with that. But in 1 month time, the patient not showing any improvement, then I would go ahead and do a thoracoscopy in this patient. I'm not going to wait in this patient for 6 months. Just
Right.
1 month of ATT trial and then do a thoracoscopy.
Right. Um, so if the patient is undergoing a thoracoscopy, I mean, is histopathology enough, or should we send the sample for expert and cultures as well? Anyone can answer that
We
very
should, we
quick.
should,
We should
we
always.
should
I think
always.
I would just
Dipesh?
like. Huh, sorry, sir.
No, nothing. Carry on.
I would just like to add on the paper which we published based on this thoracoscopic biopsies back in 2018. So, pleural fluid expert and culture have this yield of about 14% and 17%, something like that. It's always less than 15%. But when the thoracoscopic biopsy was sent for expert, the yield was 45% on that, and the culture yield was around 38-39%. So we actually concluded saying that thoracoscopic pleural biopsies provides better diagnostic yield if it is tuberculosis. So as sir rightly said that, if in India, even if you're suspecting, malignancy, anything can be TB. There are gross appearance may appear like TB, but malignancy, it may still be TB. So it is worthwhile sending uh, samples for TB, whether it be expert or culture, whatever is the facility available. But it is very, very pertinent, especially for our country. Um, Anything,
Uh,
sir? Sushil, sir, you want to ask? And this primary pleural TB, actually, we do have few cases, surprisingly. So I think it is
what
worthwhile. We should send.
What I learned is that, yes, I agree, but what I'm saying is in patients who have borderline ADA, I would probably now have started tilting towards going a thoracoscopy in them, because we have found few cases when we actually had a different diagnosis, or now this is an MDR. So someone who is having a borderline ADA, I would less than 40, at least I would go ahead and do it. A patient who's fitting into clinical scenario, young patient with a pleural effusion, a typical case of like looking like a tuberculosis and no other possibility, then you may consider starting an AKT in a patient who having ADA more than 40. But then in case you have a slightest clinical doubt, then probably I think go ahead and doing a thoracoscopy would be advisable. So your clinical judgment would be definitely important. I would not completely refute ADA that it doesn't have any role. So in a specific clinical condition, especially in Indian conditions, I would say ADA still has a role. So if you are a young patient with a high ADA and exudative lymphocytic effusion, I would still consider starting AKT first. But in this patient, I was surprised because we didn't expect it to be an MDR, and it turned out to be an MDR. So it was a lesson for me that for every patient who is suspecting TB, if you're doing a thoracoscopy, probably not, it's not just the tissue diagnosis or gene expert, but should also send for cultures. Role of cultures is very important if you are doing a thoracoscopy and pleural biopsy, especially in Indian conditions. That's what we all, I think, I believe that this should be an important lesson for the postgraduates, that if you are doing a pleural biopsy in Indian conditions, don't just send for histopathology, but also for gene expert and TB cultures. That's like what we learned. Another important question I want to ask to Manoj Goel, sir. So, what do you think is the role of gene expert in pleural fluid? That's a lot of controversy about it, and that a lot of people have a different opinion about it. Though we still feel that it is useful in some patients. But then, what's your opinion?
Gene expert is basically used for ruling in tuberculosis rather than ruling out.
Hmm.
I would invariably send, and though the sensitivity may be 20% or 30%, but if it
Yes.
is positive, then we know it is tuberculosis. All
Yes.
right. So I'm not talking about the barring exceptions which are there always,
Hmm.
but it does not. If gene expert negative does not rule out the possibility of tuberculosis,
Agreed.
that is important. So we would always do it. WHO says, the WHO guidelines suggest do not do gene expert in pleural fluid, right? Because they don't face tuberculosis there. But here we do a gene expert because tuberculosis is very much rampant endemic, to rule in rather than rule out.
So, because I think WHO is doing in a larger scale for the community, so probably for them it is not practical,
Yeah.
but for individual patients, I think it's a in our practice it is important. And a positive gene expert, as you rightly said, is like confirm the diagnosis of TB, and negative doesn't rule it out. So that's, I think, important.
Yeah.
So
And also because NTEP basically says no is because of the reason the cost involved and the diagnostic yield is pretty low, less than 15%, so they don't want to use it. Also, sir, I just wanted to add two things. The the picture, thoracoscopy picture, which was shown where there is whitish nodule. I say that as a pustule word, that the one which is, if it is
yeah.
present, it is very, very, very much classical of tuberculosis. Nagarjuna has published the paper while we were just waiting to publish it. And I've also seen that if you take up this whole thing, if you're seeing something like this, take up the entire thing and send it for the culture alone. The diagnostic yield for expert is excellent in this particular sample. Also, if just wanted to know if the report is something like expert low indeterminate, where should be tilt to?
And it is a clinical scenario. Now we got the NGS there. So
Yeah.
in doubtful cases, we can do NGS to be more sure about it. But in gene expert positive, maybe indeterminate, the clinical setup is such that TB is a possibility. I think we should go ahead and treat these patients.
Yes, sir. No, no, no. So what I want to say is, if it is there indeterminate, when it says it is not saying susceptible or it is saying not saying resistant, probably we should err on the susceptible side and wait for the cultures to come and then accordingly change.
So we
Yes.
continue with the normal 4 drugs AKT and wait for the sensitivity report. I think that's the
Yeah,
way
yeah.
we all do. Uh, I think move on to the last question to Dr. Vishnoi. Dr. Sukhram, are you
Ji.
there?
Yes, sir.
On the way.
Dr. Sukhram, again, an important question from the surgical perspective. Now, role of surgery in a case of MDR tubercular empyema. Again, a difficult situation. So, what do you think and how do you approach such patients? What's your opinion on that?
Sir, if it is proven MDR, now whether by the culture or by the gene expert, and there are two what we get patient, one is that the normal ATT was not, empyema was not responding to normal ATT. It is being upgraded as a labeled as a MDR and given a therapy and then sent for the decortication. That's the one situation. The other one is being proven with the gene expert or by the culture and started on the treatment. Now, both the situations are completely different. Way back when we published our first paper on the empyema, the 20% of the empyema being treated as a MDR, they turn out to be on the surgical biopsy and surgical culture, they turn out to be the normal empyema. Now, whatever the method they being labeled, that's a debatable issue, but they were treated as they were given as a MDR therapy for the treatment. Now there are certain patients who are being proven as a MDR, like gene, whatever the method, like gene expert, because nowadays there are so many methods where the MDR can be proven. Earlier it used to be culture only. So if it is MDR proven, then I would like to have the MDR therapy for 2 months and then operate those patients. Not they straight away for the taking them up for the surgery. Two
Yes.
months of the tubercular therapy and then taking, so those patients have the better outcome in terms of they will have less air leak and the chance of recurrence are less. Not that these patients will have the early recovery, no, but then they have the better outcome in terms of the air leak, because by the time these ATT start working and these air whatever we are seeing here on the parietal pleura, same thing mostly we see on the visceral lung or visceral pleura also. So when we remove them, there are small alveolar fistula forms and they give the air leak in case of active TB is there. But if it is 2 months of ATT, roughly we operate them with the complete wax decortication, and those patients give the better result rather than starting straight away taking them for the surgery. But in terms of recurrence, I did not find any difference between the normal empyema and the MDR empyema. We are doing decortication at the early stage or late stage. That same. But yes, in the terms of 2 months of ATT in MDR and 2 to 4 weeks of ATT in the normal empyema, and then operating them is a better choice, a better outcome than the straight away taking them for surgery.
Thank you, Dr. Bishnoi. Is there any technical difficulties in managing MDR as compared to normal empymas, or no, they're the same?
No, it's 100%. It's completely different ball game. If it is normal TB, it is easier. There are easy planes. If it is MDR, I know it because whether it's being sent it or not, the culture earlier proven or not, it will make you realize that I am MDR. The planes will be difficult, stuck to the chest wall, stuck to the pericardium, diaphragm, everywhere, and they have more bleeding. So obviously the surgery will be difficult in case of MDR.
Okay. Thank you. Dr. Richa, any questions?
No, nothing. I think we have a pretty good discussion, and I hope few questions would have been answered for the people who have been seeing. So, shall we just conclude on that?
Yes, please.
All right. So, before we conclude, I'll just put up just try to summarize the thing. The first case we learned that it is good to do an early referral to surgeons when it is required. We should not intervene as a physician. The second case was interesting again, bilateral chylothorax. We should do the complete workup, which includes scintigraphy, and it may require even thoracoscopy because there may be we need to rule out. And if you're not able to find any case, then send it to your person whom you don't like to manage that case of chylothorax. It is very difficult to manage. So complete workup is really, really required. And then most of the time, idiopathic, just managing conservative management, managing with octreotides and medium chain triglycerides diet does help. Third case was another interesting case, something an eye opener that in India, everything and anything can be tuberculosis. So, especially when you are doing some test like medical thoracoscopy, which you won't be doing it again, please make sure that you send all the samples, including the cultures as well as the MTBs, cultures experts, and histopathology. So, I want to thank our esteemed panelists, Manoj sir, Dr. Sukhram, Dr. Dipesh, Dr. Arpan, and our presenters, Dr. Urvashi, Dr. Rishabh, and our beloved, where is he?
Dr. Urvashi.
He's there, Dr. Ravi. So thank you so much, everyone, for jumping into a very active discussion, and I hope it would have been useful for the people who were watching. Thank you so much.
Thank you.
Thank you, ma'am. Good night.
Thank you.
Thank you.
Thank
Good
you.
night.
Thanks
Thank
to
you.
all the panelists and the presenters, especially the DNB students who have really done very well. Thank you. Thank you, Manoj sir. Thank you, Dipesh. Apar unfortunately could not join us. Thank you, Dr. Sukhram.
Thank you, sir.
Thank you, Ravi.
Thank you, sir. Thank you. Good night.
And I think we close the session for today and hope that Dr. Arpan, thank you.
Thank you, sir.
And we close the session for today and we hope that we'll continue doing it. And soon we'll come up with the next Plural MDT in the month of March. Thank you, everyone.
Thank you.
Thank you, and
Thank you.
have a happy
Thank you.
weekend. Good night.
Good night. Good night. Good night.
Thank you. Good night.